Systemic lupus erythematosus is a chronic multisystem autoimmune inflammatory disease that has variable signs and follows a relapsing and remitting course. More than 90% of cases of systemic lupus erythematosus occur in women, commonly of childbearing age. This condition can lead to complications such as acute or chronic renal failure, seizures, psychosis, pleurisy, pleural effusion, pneumonitis, pulmonary hypertension, pericarditis, myocarditis, leukopenia, lymphopenia, thrombocytopenia, and interstitial lung disease. The management of systemic lupus erythematosus often depends on the individual patient's disease severity and disease manifestations. Causes: autoimmune, genetic and environmental factors. Symptoms are fatigue, malaise, fever, weight loss, rash, hair loss, mouth sores, joint pains, sensitivity to sunlight, seizures, nausea, dyspepsia, abdominal pain. Signs that are usually elicited are lymphadenopathy, fever, malar rash, discoid rash, fatigue, arthralgia, arthropathy, myalgia, arthritis, and photosensitivity rash, and also anemia. Investigations are FBC, ESRB, creatinine, urinalysis with microscopy, C-reactive protein, anti-nuclear antibodies, anti-double stranded DNA, dsDNA, and complement levels, liver function test, sports urine protein or sports creatinine ratio, other autoantibody tests, for example, extractable nuclear antigens, as ANA, and hepatitis B and C screen, HIV screen, joint radiography, chest radiography, echocardiography, brain MRI, or MRA. The main treatment objectives are to control symptoms, to adequately control underlying disease, to prevent and treat complications, and also to avoid possible long-term effects of the drugs. Non-pharmacological treatment: avoidance of excessive sunlight, rest as appropriate, low-fat diet with added fish oil, avoidance of estrogen-containing contraceptive pills, counseling and education. So vaccination: you avoid live vaccines in patients on greater than 10 milligrams per prednisolone or immunosuppressives, and in patients on immunosuppressives there may be a reduction in vaccine efficacy, but there is adequate humoral response to hepatitis B, influenza, and pneumococcal vaccines. Pharmacological treatment: for acute flare and maintenance therapy, first-line treatment, you give methyl prednisolone IV infusion, infused over 1 hour, in adults 1 gram daily for 3 to 5 days, in children 1 month to 18 years. Give 10 to 30 milligrams per kilogram every other day for 6 doses with a maximum of 1 gram daily. And then you give prednisolone oral in adults and children 0.5 to 1 milligram per kilogram body weight. You take corticosteroids after food, and high dose glucocorticoids may cause insomnia. Immediate release formulation is typically administered in the morning to coincide with circadian rhythm. After this, we give omeprazole oral, as after the prednisolone oral. Omeprazole oral in adults 20 milligrams daily. In children having a weight more than 20 kilograms, you give 20 milligrams daily. And for weight 10 to 20 kilograms, you give 10 milligrams daily, and 5 to 10 kilograms, you give 5 milligrams daily. You can also give esomeprazole oral in adults 20 to 40 milligrams daily. In children 12 to 18 years, you give 20 to 40 milligrams daily, and 1 to 12 years, you give 10 to 20 milligrams daily. Less than 1 year is not recommended. You can also give diclofenac oral in adults 50 milligrams 8 hourly or 100 milligrams 12 hourly as required. In children more than 12 years, you give 50 milligrams 12 hourly as required, and less than 12 years is not recommended. Or you give diclofenac rectal in adults 100 milligrams 12 hourly as required. In children and more than 12 years, you give 50 to 100 milligrams daily as required, and less than 12 years is unrecommended. Or you can give Cholicoxib oral in adults 400 milligrams stat, and then 200 milligrams 12 to 24 hourly as required. In children, more than 2 years with weight more than 25 kilograms, to give 100 milligrams 12 hourly as required. More than 2 years and having a weight 10 to 25 kilograms, to give 50 milligrams 12 hourly as required. Less than 2 years is not recommended. And you can give paracetamol oral in adults 500 milligrams 1 to 1 gram 6 to 8 hourly as required. And in children 6 to 12 years, you give 250 to 500 milligrams 6 to 8 hourly as required. And 1 to 5 years, you give 120 to 250 milligrams 6 to 8 hourly as required. And 3 months to 1 year, you give 60 to 120 milligrams 6 to 8 hourly as required. And then you give calcium with vitamin D supplements in adults and children as required. And then the following medications will be used in addition to the treatments under specialist care. So you give biologic DMARDs. So that's belimumab. For this you have to consult a specialist, and also write tuzimab. So write tuzimab and intravenous immunoglobulin. So you have to consult a specialist when you're giving these. Or non-biologic DMARDs like cyclophosphamide, methotrexate, azathioprine, mycophenolate, and cyclosporine. So all these you have to consult a specialist. For antimalarials, you give hydroxychloroquine, but you have to consult a specialist too. Referral criteria: refer all cases to a specialist or rheumatologist. So let's look at the recommendations for the use of conventional immunosuppressive drugs in lupus. Okay, we look at the symptoms, medicines tried, and the dose and duration. For arthralgia, the medicines, you give non-steroidal anti-inflammatory drugs, dose and duration, avoiding renal involvement, and use briefly. For myalgia, you give hydroxychloroquine as under specialist care. Lethargy, annual retinal checks, ES, that's the duration, and the baseline and frequent monitoring for those with baseline eye problems. For rash, the medicines to try: hydroxychloroquine, topical steroids, or tacrolimus, and the duration and dose specialist care. For arthritis, medicines to try: prednisolone, and this prednisolone 20 to 40 milligrams per day initially for 2 to 4 weeks, reducing in 5 to 10 milligrams increments per week. And if the patient is responding, treatment is likely to be required for several months. For hydroxychloroquine, as in arthritis, and methotrexate in refractory cases, you have to refer to a specialist. Pleuritis and pericarditis, give NSAIDs, medicines to try: NSAIDs, antimalarials, and low dose corticosteroids. So 20 to 30 milligrams prednisolone per day, and then tapering doses along the lines of arthritic treatment is recommended. So you refer to a specialist too. So also for pleuritis and pericarditis, in refractory cases like azathioprine, mycophenolate, mofetil, or cyclophosphamide. When you give these medications, you have to refer to a specialist. The autoimmune hemolytic anemia or thrombocytopenia, the medicines you try are corticosteroids, often accompanied by azathioprine or cyclophosphamide. And also rituximab. So this medication, after this, you have to refer to a specialist. 60 to 80 milligrams prednisolone for 1 to 2 weeks, reducing in 10 milligrams increment in response to blood test results are recommended. So let's look at the symptom right now. So medicines to try: prednisolone plus cyclophosphamide or mycophenolate mofetil, azathioprine or mycophenolate mofetil for maintenance, and rituximab for refractory cases. And the dose and duration, refer urgently to a specialist to deal with that. So central nervous system symptoms: the medicines you try are corticosteroids plus an appropriate drug like an antidepressant or anticonvulsant, among others. Controversial 20 to 60 milligrams prednisolone daily is recommended. For central nervous system medications, for central nervous system symptoms and medications like rituximab and cyclophosphamide, you have to refer gently to a specialist when these medications are being used.